Hello, today I'm going to show you a valve-in-valve TAVR workup on 3Mensio in a patient with previous transcatheter aortic valve replacement or TAVR. And now this patient is being evaluated for Redo-TAVR. So this patient has a 23 millimeter balloon expandable valve, a 23 Sapien valve. And so I'm going to show you how to work up the CT to see if Redo-TAVR is feasible. First, it's important to get some records information ahead of time. So number one, we like to get the pre-TAVR CT, the CT that the patient had before the first TAVR, to check some of the native aortic anatomy and measurements to see whether the valve is properly sized, any hostile anatomy that would increase the risk of PVL and other findings, and also the measurements such as left main height and the sinus height that would allow us to get a reference of the annular plane of the new CT, because now with the transcatheter valve in place, it's almost impossible to get the true native annular plane unless you have some reference landmarks in place. The other thing we typically ask for is the intra-procedural aortic angiogram or the procedural fluoroscopy to get an idea of what happened during the initial procedure, and also to assess the implant depth and potential even redo TAVR feasibility just from that final aortic angiogram alone of the aortic root, because often you can see whether redo TAVR is feasible just by that. In addition to the CT, I would also suggest you get a cardiac cath and actually go to the LAO cranial view, take the parallax off the transcatheter valve and do an aortogram to see what the relationship between the transcatheter valve frame and the left main looks like, to determine coronary obstruction risk and risk of sinus sequestration. Because there might be motion artifacts or quality degradation with the CT, with the transcatheter valve in place, or in booming artifacts, the fluoro and aortogram is actually more helpful in terms of defining the true risk of coronary obstruction and sinus sequestration rather than just CT alone. So with that in mind, I'm going to show you now, this is the main screen after you click automatic segmentation in the aortic valve software. And you can see that I'm going to get rid of these center lines at the aortic root because that's not necessary. So similar to the surgical aortic valve, what we like to do is to get the center line across the transcatheter valve, because sometimes the transcatheter valve may be canted one way or the other, just like a surgical valve may. So you want to actually center line to the transcatheter valve to get an accurate measurement of the frame and also distance to the coronaries. So you can see what I'm doing now, it's exactly doing that. So first, I'm going to try to get the inflow dimension. And to do that, I want to drop the gain. Remember that booming artifact. So you want to make sure you measure the internal diameters accurately, just like what you do with a surgical valve. And then what you're trying to do is to try to get a center line so that you will be able to have the frame appear at the same time. So you can see that here. This is fortunately a pretty high quality study. You can see there's very little motion artifact, very high resolution of the transcatheter valve. I also did a redo TAVR with balloon expandable valve recently as well on a 3Mensio video tutorial with a valve quality that's a bit suboptimal with motion artifact, just to compare the difference. So you can see now how it looks, and I'm going to go to the inflow and see this looks pretty good. Now, what I do next is to actually come up, and this patient actually has a bicuspid aortic valve, but you can see the sinuses here. So similar to what I do with the native TAVR workout that you've seen in the prior video, I bisect the sinus and I put a dot at the base of the Sapien valve frame. I do the same here, about roughly 120 degrees, because remember the transcatheter valve is 120 degrees apart. And then I get to the bottom, and then now with the yellow dot, I try to see where the valve frames start to appear and see if I can get it exactly at that plane. This is not the annular plane, okay? This is not the true annulus. This should be, unless you implant the valve at 100, 0, with 0 depth, then this would not be the true annulus. So you can see I'm trying to figure that out. Now remember also, the transcatheter valve may foreshorten a little bit differently, especially with balloon expandable valve, such as asymmetric expansion and asymmetric foreshortening. So sometimes the height might not be the same either. So you can see how I'm trying to get to the measurements here. And that's actually pretty good. Sometimes might not be perfect like you see here. We certainly looking at all the different dimensions. You can see now that's a better center line. So that looks pretty good. Just overall in terms of how it might be. So once you decided that, you can click confirm. And this is the inflow of the transcatheter valve. So I'm going to do a lasso to look at the frame to see if it's well expanded or not. I draw it right across from the frame rather than the outer diameter. If you do the outer diameter, you overestimated the area and the dimension. If you do it in the inner, that'll be more like the internal ID, internal diameter of the transcatheter valve. So that could be helpful in terms of sizing for the new valve. But remember, the balloon expandable valve can be more expanded, especially if it's underexpanded. You can see that currently it is, because you can look at the frame dimension of here. This is a 23 Sapien 3. And you can see that here it's about 22.5, so it's not fully 23. So there's potentially room to expand this more. And you can also see that this has some eccentricity to it. You know, the valve should be more or less circular in a balloon expandable valve. So again, that is something to watch, and you can potentially make it more circular. So I'm going to save this 23S3 inflow. Okay, and then I'm going to also try to crop these to set up my left main and right coronary view here as well. So I want to see where my right coronary sits. You can see that here. So, and then I'm going to go next to the outflow. So the outflow is right around there where the crown disappears. And the nominal height of the Sapien 323 millimeters is 18 millimeters. So this is pretty close to nominal. You can certainly measure that. This is 18. You can denote that height. And you can draw the circle on the lasso tool to measure the frame dimension on the outflow. You can see a bit eccentric, but still a little underexpanded as well. So you can save that at, you can see 23 outflow. And then now I'm going to split the difference and look at the mid frame. Here, 9 millimeters, so you can see. And I'm going to measure the dimensions here to account for the frame geometry. You can see here, look at that. So a 23 millimeter valve is now only 20 millimeter in terms of mid frame dimension. So it's quite compressed and underexpanded, and also a little elliptical as well. Now, could it be the reason for its degeneration or failure? Possibly, but certainly it's an interesting hypothesis, especially in the context of bicuspid valve. So again, how do you determine the true annular plane? It's hard because you have the booming artifact, but you also have some motion artifact to determine where the sinus actually is disappear. So you can see that here, this valve might be a little bit canted because you can see the sinuses disappear on the right and the non, but you still have see some on the left. So you might not be able to determine that, but certainly having a previous CT, you will be able to do those measurements. And you can actually look at that more systematically. So I'm not going to do those measurements here, unlike my other tutorial with another Sapien 3 Redo-TAVR workup. But I'm going to show you something else that is important. So you can actually see the STJ here, the sinotubular junction. That is where the coronaries already take off. And you can also put a STJ measurement here. The only caveat is that you don't know what the true annular plane is, so you don't know what the sinus height is. So, but that might not be as relevant here because what matters is the risk of sinus sequestration and coronary obstruction. But it's still worthwhile to just, perhaps get an idea where the sinus or salva is the biggest. And you can see that here, perhaps we can do that. That's 1, that's 2. This is a bicuspid valve, so it might be a little bit asymmetric. And you can see that here. So this is the left sinus. This is the right sinus. This is a non-sinus. So what we can do is to put that in here in terms of STJ. You can put that into those, and then the sinus height, sinus width as well. And now we look at the left main here. You can see this is where the left main. It's hard to know where the annular plane is, but you know it looks like almost 100-0 implant. You can see here the sinus goes all the way to the inflow of the frame, so I can put that as a left main height. This is the left sinus height. So we'll right-click and measure from basal plane, and just for the simplicity, I'll put that as the sinus height, assuming that is the base of the annulus. So now I'm going to look at this distance here, right? This is the key where you have the risk of coronary obstruction. So I'm going to go back to the top of the frame, and you can see that here. And I'm going to measure the distance between the frame and the coronary distance. So this is the coronary distance. And I'm going to do the same here. So this is what the virtual valve to coronary distance is. Okay, so roughly here. Now, if the frame is above the STJ, then you would do the VT STJ, valve to STJ distance, because that will determine whether you have sufficient diastolic flow after the second transcatheter valve goes in. And if you put a self-expanding valve up, which is supraannular, you'll need to definitely consider commissure alignment, because if you have a commissure post that faces the left main here, coronary access will be definitely more challenging than if the commissures are aligned. So, but here you can see the top of the transcatheter valve frame here. After you put it in, it will be like a surgical valve, where this will now become a tube graft. So you want to make sure there's sufficient clearance here. People say around at least 2 millimeters, but the more the merrier, obviously. And so you can see that the coronary height can be quite high, but if the valve frame is above it, you need to make sure there's clearance, and also from a future coronary access standpoint. So that's the left main, the VTC. You can see the right is also coming up as well. So I'm going to go here to try to get the top of the frame again, and then measure the distance. You can see a little bit more generous here, 4.8. You can also see that here. It's really just against the orifice. So, and you can see that that will be the right coronary height, roughly, assuming that's the base of the annulus. But you can see actually that's the differential implant, asymmetric implant. You can see the sinus cut off almost here. So actually the right coronary may actually come off here rather than there. So let me delete that. Custom. Maybe this is more the coronary height, right coronary height. And then you can see this can still be the sinus height here. So here's what it looks like. And then I'm going to basically go back and measure this. And take a snapshot here so they can see the distance. A lot of numbers here, but you can see that that is the VTC. And then I could go to the right coronary here. Now, it's important to also look at the commissure orientation of the transcatheter valve. You can see that this is a very nice study. So you can see on diastole, typically that's what the space that we look at with Redo-TAVR anatomy. And you can see that the nice commissure orientation. And in fact, you can mark this here using a marker tool. And you can mark the commissure post, so you can actually reference it across the entire cross section. So you can see that there. And you can see that also here. So you can see also the commissure post actually will thicker. So that's and then also what you can do is to get an angle between the coronary. So this is the left main. And then you can look at the right, where the right takes off. So it actually is pretty good right there. So you can actually mark this image. It's a very useful image to actually save, because now you can see how the coronary is relative to the commissure. So in case of commissural misalignment, you know ahead of time whether this will be a problem with Redo-TAVR and also potential leaflet management strategy, whether you can do basilica or not, based on this orientation. So I typically put 23 as 3, commissural orientation to left main or RCA. Okay, so and then also what we need to look at and save also is the whole idea of the BTC. So we'll save this. This is a very busy slide. I'm just going to put that right there. And you can see this is the BTC of the left main and on the right. At the top. So now what you can do here, a couple other views that you can use. One is a hockey puck view. So what you do is to go to like what we do with the native TAVR workup, and you just drop the gain and you zoom in, and then you look at the orientation here. And then you can see how elliptical that is. The other thing you can do is now you can go to a more coplanar view, assuming you have a pretty good coplanar angle, and you can see now how the orientation, the commissures are, and also how kind of a hourglass shape this this valve is. So you can actually measure the frame distance here too, just to see how well it's expanded. And you can see that here, and you can also measure the height. So that just gives you an idea. You can save this. Very busy slide here, but you can see this is a better resolution of your image than the Axo scan or the regular 2D scan. So you can actually get a better idea of your frame dimension, and you can actually save that. And this is a more like a free cuts view. You can also actually rotate this to do more like a cuts overlap view, because that's a short axis of the valve. This is more helpful in the case of a self-expanding valve to evaluate that. And you obviously have to redo some of the measurements. I'm just in the interest of time, just move this around a little bit to remeasure. But this should be probably a little bit different. You can see that here as well. And you can actually do the same thing and see the difference in terms of the valve expansion at different parts of the 23 Sapien 3. So let's look at the report. So you can see I can put the mid frame here. This is STJ, this is SOB. So I'm going to put the commissure orientation up here. There's no standard format on this kind of workup, but this is kind of my preference on how it looks. Out to frame distance and this, and then some of the frames. So in this case, you can see here, we have a VTC of 3.1 is going towards STJ. It should be able to do Redo-TAVR. Now, remember, you're going to put a second valve in there, a balloon expandable valve, and you want to expand this further because this is underexpanded. You might reduce this distance to the coronary. So you might actually risk coronary obstruction if you expand this further. Just keep that in mind. So, and if you don't, the trade-off is that you might have an underexpanded second valve and lead to subsequent hemodynamic compromise and maybe even durability. So just keep that in mind in terms of pre-case planning, what you want to do, whether you want to expand this fully, which I would recommend first, so you can fit a better transcatheter valve into a lot of better expansion of the second valve, because usually the second valve would be even more constrained. But you can see that this valve is clearly more elliptical than what you expect, and underexpanded. That may be one of the reasons why it failed. So I would save this. You can save this a PDF and share with your heart team. And of course, you can save this session as well. So I hope this is helpful with the analysis of a Redo-TAVR with a previous balloon expandable valve with potentially high risk of coronary obstruction and sinus sequestration. As you see, this is a very high implant. This is a study that is a very high resolution, very good quality. You can see the commissural orientation very well. So this is a kind of ideal study for to look at Redo-TAVR. So I hope this is helpful, and we'll see you next time.